First of all, a very warm welcome to each one of you who is present in the class for this very special.
साथिव लाइव कर दिया क्या? एक मिनट.
Okay.
या ठीक है.
Thank you and welcome again. So this is a very special class for, we named it as master class for all the Australian Medical Council aspirants who are seeing themselves to work in Australia in the coming future. So to begin with, we have a very powerful team of Academically. So on behalf of each one of the team member, I welcome you all for this very special session. And the face on your screen right now is the mastermind for all these classes and what all we are here for. So now I'll hand it over to Dr. Akram from here.
So hello everyone, this is Dr. Akram here. So this is, we will take your questions after this session. So you have, whatever you have questions, you can ask. So we will also let you know what is the process to migrate to Australia, what are the exams you need to pass, what are the steps you need to take to migrate to Australia, all those things. And then our faculty will take a very small topic, and that how we are going to prepare for you for the AMC course, so how you can migrate to Australia. But if you have any questions, so we will take questions at the end of the webinar or maybe the master class. Okay, so just stay tuned with us. You can hand over to Roda.
Yeah. So thank you, sir. As you can see on your screen right now, the slides that I am scrolling right now will be taken care very nicely after the session, that what all you need to do, how many papers are there. So now I would love to request our very learned faculty, Dr. Udara and Dr. Swapnil, to take on from here. So the session will be bifurcated into two parts. Dr. Swapnil will be taking care of all the basic requirements that what you need to know about the course. After that, there will be a very smart session by Dr. Udara to give you a little glimpse of how we work and all. So from here, over to Dr. Swapnil first.
Hello, everyone. Thank you, Bharti, and thank you, Dr. Akram, for giving me this opportunity to explain to the students about what AMC is all about. So very briefly, today we will be actually taking care and understand that what Australian Medical Council MCQ exam is all about. So this is necessary because before we attempt or try and prepare for any exam, we should know what that exam is all about and what that exam is expecting out of us. So to begin with, what is AMC? This exam basically is being conducted by Medical Council of Australia and actually tests the knowledge at the level of someone who has just passed his undergraduation or MBBS examination and is at the level of intern training. So the knowledge which is tested is that level that we have to keep in mind. Secondly, what is this all exam is all about? So it will test your clinical medical knowledge, application, and your professional behavior. So these are the basic thing which is being done in the exam. And if I tell you about how the exam is being formatted, so it is about 150 question. We all know it is a multiple choice question. What we have to keep in mind is the duration is 3.5 hours. So basically we have just 1 or 1.5 minutes for every question, and we need to complete all 150 questions. We cannot left any question unanswered. The good point is there is no negative marking, so we can attempt the questions without regret, but we have to attempt every question, because if we do not attempt a question, then the results can be considered as fail. You have to complete all 150 questions to get the result. Now, there is one thing how these questions are formatted or where these questions are coming from. So whatever I'm telling you or whatever my content today is from the AMC website only. And in the website, it is mentioned that half of the questions are calibrated from the previous pool and half of the questions are newly formed. So what is that previously calibrated pool? That is a pool, or that those questions are one which have been asked previously, and they are again testing the same knowledge on the new applicants. So that means that if we know that if we could get a good hold of questions which have already been asked or the topics which are already being asked, we have a very good chance that we are 50% thorough with the exam. We just need to work on those new questions which are coming up, and that we can do it by applying our medical knowledge which we have acquired over the course of the duration. Now, how the questions are being framed, or what is the content or what subjects are being covered. So first thing to understand is AMC is based on, or the questions are based on clinical application. So you actually cannot segregate on that on the basis of subjects, like this is a medicine question or this is a surgery question. But to have a good preparation, we study it in that format. Also, AMC is not about facts or ideas. It is not about learning facts, like how much of this is happening in this person or how much is happening in that. It is not about facts. It is more about your clinical application and knowledge, and how do you apply that knowledge. So what are the categories in which we will be covering this course, or the questions are asked? So it is adult health, which is your medicine and surgery part, then your women's health covered in obstetrics and gynecology, child health or pediatrics, then your mental health, and very important part of AMC exams, which we as international medical graduates generally suffer, is population health and ethics, because everywhere the ethics is different. So standards in Australia is different, and it will be different in a country where you have graduated from. So that is an important part to be considered. Now, the questions can be asked on different things. It can be in the form of a pathogenesis, clinical feature. You can get questions on management, investigation, differential diagnosis. Anything can be asked in the exam. Coming to what percentage of things are asked. So before going into that, I would like to address that questions can also be asked in the form of images. So you can have an X-ray image, an ECG image, of clinical photograph. Anything can be there, and they can ask you questions on that. So sometimes questions like a clinical image of a rash can be there, and you have to make a differential diagnosis. ECG can be given to you, CT scans, X-rays, anything can be given, and that is also a part of AMC exam. Then, and as I addressed, that this exam is not about facts. It's about it's not about rote learning. It's about your clinical application. Also, not only these topics are being covered. Sometimes certain topics or certain diseases which are more prevalent in Australia, we need to know more about that, because those are part of the MC exam questions. And also, there is difference in the diseases in first developed countries and developing countries, and so on. So that all things we have to keep in mind. Coming to the next thing, how we distribute the percentage of MCQ questions. So this is a journal, snapshot which is there, but this is not hard and fast or very thoroughly followed. Sometimes you can get more questions from one categorization, sometimes you can get it from other subject. But generally, it is said that adult medicine comprises 30%, surgery is 20%, and rest all other subjects actually take over your 12.5% of the questions. So among 150 question, if you see, most of the questions as described come from the medicine part, but I have seen questions coming from like more of from other subjects as well. So we cannot hold on to this. We have to prepare everything in detail in a thorough knowledge. Coming to the next type, how these questions are, or what are these? So these are A type of questions. So what are A type of questions? So you will have a STEM and you will have 5 options. You have to pick a correct option. Now the thing with AMC is there, if you can see, that the answers, like when you will see the question, every other option will be a good a differential diagnosis, or that could be answer, but that will be a partially correct answer. You have to carefully read the STEM and to find out one option which best fit to that STEM. So even though you can find that the other option is also correct, but you have to figure out what is the best response. So that is the thing with AMC. It will have 5 options, and that is why we need to that is how uh, our reference material should be so wide that we have thorough knowledge about that we can exclude all other options when a question come to us. When we have 150 questions and every question is having 5 options, we need to have that much of thorough knowledge to come to a good conclusion for one single best answer. Good point. There is no negative marking. And as I have said, the next important point about this exam is very important point is that even though you score, like as it is said that the total scoring is 500 and you need to score 250, that doesn't correspond that out of 150, if you have made 75 questions correct, you are passed. No, it is not like that. AMC does not work on this scenario. The scoring is not simply based on how much correct answer you have given. Every other question is not marked as equal. For example, I don't know what is the marking, no one knows, but it is not like that if a question A is marked as 3 marks, question B is also marked as 3. No, there are priorities set. There are priorities set as difficult and easy question, and no one knows which question is difficult, which question is easy, and what's going on. So every other question is not marked as equivalent. So we cannot figure out which question has high score or which question has low score. So we need to prepare to attempt all 150 question as correct, because the thing does not work like out of 150, if you have made 75 correct, you pass the exam. Another important point, passing score out of 500 is 250. The AMC gives, when the AMC present to you the results, it is marked in all those 5 categories, whether you have satisfactorily performed, whether it was borderline or it was below borderline. That is how the scoring is done. I have presented a sample question. So this is a sample question taken from AMC website only, and this is how the question comes. So in this question, if you see, there is a small child of 20-month-old boy who is coming with his mother to the supermarket, and he has put lollipop in the trolley and becomes engaged with his mother, put it back. He starts to cry vigorously and suddenly stops breathing. He becomes cyanosed, lost consciousness, and has a brief tonic-clonic seizure. On examination, 15 minutes later, he is alert and interactive. His BP is 95/60 and pulse is 100. Temperature is 37 and neurological examination is normal. Which one of the following is the most likely diagnosis? Now, if you see the options, every 5 option which is given in first attempt will you will think that everyone is fitting to the scenario and every other option is correct. But no, we have to figure out or rule out other options to find a good option or a diagnosis which best fit this scenario. And there are some pointers which we have to keep in mind while solving these questions. So next, coming to what are the resources. So these are some few resources which are gold standard to prepare for AMC exam. We always starts with handbook of multiple choice question, which is also known as blue book. Then there are annotation of multiple choice question book, anthology of medical confusion, and for ethics we use good medical practice. Next coming up slide, I have attached the links which are from the different guidelines which we use, different reference material which we use when we solve questions, because everything is not covered from the reference textbooks. So we make a good combination of textbook as well as the reference guidelines which are followed over here. So that was all from my point. Thank you so much.
Thank you, Dr. Swapnil, for elaboratedly explaining all the points that need to be hands-on ready with the students. So now I would love to welcome Dr. Udara. Thank you, Dr. Swapnil.
Yeah, hello everyone. I hope you guys can hear me properly. So actually, when it comes to the academic session, we just wanted to give you an idea how the AMC actually have their content prepared by them already. So because like we all know, like all the contents and everyone that who did an MBBS is aware about so many health conditions. But the problem with the AMC is, even though that we are 100% know all the topic and all the content in it, sometimes there will be some guideline changes in the management or in the diagnosis, which only AMC websites or AMC guidelines or sometimes the medical council guidelines will show for us. So everything that should be mainly known by the guideline which they actually give us. So I am actually presenting some part of CVS, so cardiovascular disease, especially I'm just like presenting ischemic heart disease. So I just wanted to show you, I know that almost all the doctors will definitely be more aware about ischemic heart diseases. I just want to show you and like point you out that there will be some guideline changes that they have differences in management. So actually, when we come into ischemic heart diseases, we all know that what is ischemia. It is like mainly reduced blood flow into some part of the organ or system. So ischemic heart disease is mainly some reduced blood flow into the heart muscles. So this can be divided into main 2 parts, which is asymptomatic and symptomatic ischemic heart diseases. So the asymptomatic one is mainly clinically silent, which will not be as a presentation will be coming into the hospital. So why this reduced blood flow or ischemia occur? Mainly because of some atherosclerotic plaques that is actually formed inside of the arteries. So when we come into the symptomatic ischemic heart diseases. This also mainly can be divided into two main parts, which is stable angina and acute coronary syndrome. Actually, all the notes actually that we are giving in our academically format is mainly based on Australian guidelines, which is mainly getting by RSCGP for adult health. And if you guys, I'm not sure if you guys are aware that they have their separate guideline for therapeutic guideline, RSCGP guideline for mainly the adult health, and for the pediatric health, they will have RCH guidelines. And also mainly the reference book for all the other parts is John Murtagh. So most of the notes from our academically is based on these books and guidelines. So even the parts that I'm presenting today is based on their RSCGP guidelines. So in their guidelines, so as I said, this is divided into two main parts. So when we come into patient with any new or increasing symptoms, we can classify that as acute coronary syndrome. And if this is having chronic symptoms, mainly the symptoms with exertion, then we can mainly say it as stable angina. So when we come into separately into acute coronary syndrome, this will be mainly result from unstable atherosclerotic plaques or sometimes endothelial disruptions, which will be associated with transient or permanent thrombolytic occlusions of the coronary arteries. So this will lead into mainly ischemia, so myocardial ischemia or myocardial infarction. Then when we come into stable angina,
Dr. Ulara, can you just let me know whether the slides are in cooperative discussion with your...
Bharti, it should be the last one still. No.
Are you done with this?
No, you have to go to the second slide.
This one?
No.
This one?
Yeah. I will tell you when to change it.
Okay? Yeah, that would be.
Yes. So, okay, guys, I will just again quickly tell. So we are now coming into acute coronary syndrome. So this is resulting from unstable atherosclerotic plaques mainly, or sometimes endothelial disruption. That is mainly associated with transient or permanent thrombolytic occlusion of the coronary arteries. And this will mainly lead into myocardial ischemia or infarction that will be presenting to us as a presenting complaint. So when we come into stable angina, which is another part, so it is usually due to relatively fixed coronary obstruction produced by stable atherosclerotic plaques. So when it is in acute coronary syndrome, what we have to know is mainly how we differentiate three main parts of acute coronary syndrome. So what are the three main things? Mainly ST elevation MI, non-ST elevation MI, and unstable angina. So when we actually divide acute coronary syndrome, mainly we can divide it into two main parts: ST elevation presenting acute coronary syndrome and non-ST elevation acute coronary syndrome. And ST elevation acute coronary syndrome, we will all know. So in the ECG, they will show an ST elevation in the lead. But in non-ST elevation acute coronary syndrome, that can be again divided into non-ST elevation MI and unstable angina. So with non-ST elevation MI, usually the cardiac markers, the troponin is mainly will be positive. And in unstable angina, usually the cardiac markers are negative. So this will be the classification. Okay, so Bharti, you can go to the next slide. Okay, so when we come into the primary care investigation for suspected acute coronary syndrome, when a patient comes to us with any chest pain, so in John Murtagh and all their guidelines, they will clearly said that we will have to exclude MI by like doing all sort of investigation than doing other investigations, because, and also like going into the other differentials, it is first thing we will have to do is to exclude MI. So for that, what we will have to do is, first thing we will do is an ECG. So usually with the presentation to the hospital within 10 minutes, so these are actually important, guys, because they are said in their guidelines. So sometimes they can ask within how many time period that you will have to do an ECG. So with in their guideline, they say within 10 minutes of the presentation, we will have to perform an ECG. So other part is usually what will be presenting in there, but easily I would say, so ST segment elevation and reciprocal ST segment depression will be mainly there in ST elevation MI, and you can give it a read in other ones that what will be happening. Bharti, you can go to the next one. And then we will all know then cardiac biomarkers will be our next main investigation. So for that, we will go with a troponin. Usually troponin will be becoming abnormal in the body within 4 to 6 hours time. And usually it will be there for around 10 to 14 days. Usually first with the first one, then it will be there for like around 2 weeks time. So if they ask you a question telling that what diagnostic investigation that you should do, like what cardiac marker that you should do to check if there is any reinfarction has occurred, then we can't do troponin. So it should be CKMB or myoglobin, mainly CKMB. So because like it will be usually normalizing in the blood for usually 1 to 2 days. So even though that we do it like in 1 week time, it should be normalized if it is not a reinfarction. So usually troponin will not be checked for a reinfarction if we are suspecting. If not, we can usually go with troponin as our best cardiac marker investigation. But yeah, and then this is the most important part, the management, because here sometimes the management will be changing like 1 or 2 things. So what is the primary management? When a patient presenting to you with acute coronary syndrome and you are suspecting that this patient is having ST elevation MI or other part of acute coronary syndrome. So any patient with ST elevation MI for admission to a coronary care unit for monitoring and expert acute care. So any patient that we are suspecting acute coronary syndrome or even mainly ST elevation MI, we should be admitted into the coronary care unit. And then if these are some aspects of initial management that they have said in the guidelines. So for me, what I will be easily remembering is like you guys also may be having the same thing. So we may basically remember it as monotherapy, right? MONA. So mainly morphine, oxygen, nitrates, and aspirin. So that is the easier mnemonic that we can remember the primary management of any acute ST elevation MI. So when we come into that, there are some changes that they are mentioning in their guideline that when like all of us will know that we will do any patient coming to us with the primary management, we will go with morphine, oxygen, nitrates, and aspirin. But here they clearly say routine use of oxygen is no longer recommended unless oxygen saturation are measured at less than 93%. So only if the saturation is low, we will give oxygen to the patient. So that is one thing. And GTN should be administered to symptomatic patients whose chest pain is thought to be caused by acute coronary syndrome. Yeah, so GTN should be administered, but there are some small pointers towards GTN which will have a contraindication. Because I have seen in many AMC exams, they were pointing towards this point and framing questions about acute coronary syndrome, because they will know that we will definitely know that we are giving GTN as one of the first line management for the treatment, but if they mention this, we can't use that because it is a contraindication. So what are the contraindications to use of GTN? It is mainly suspected right ventricular MI, and this is very important if the patient has recently taken a phosphodiesterase type 5 inhibitor, mainly sildenafil or tadalafil. They will have a combined effect and cause precipitate as severe hypertension. So because of this reason, we can't use this. So sometimes when they frame the question, they will mention in the history that this patient presenting to us is already taking sildenafil as a normal regular medication. And now they are asking for the primary management for the pain, what will you go with? So at that point, you will have to have you in your mind that you can't use GTN in that patient, and we will have to go with the opioid choice in the question. And then aspirin, definitely, we will have to go with every patient. So usually 300, but there is a contraindication if the aspirin is hypersensitivity is there, so you can't use it. And IV opioids, even though we know that morphine is like always, in our minds, morphine is the more better opioids for us. But in the system, they usually say, if the pain that does not respond to GTN, then definitely go with an IV opioids. And then in recent researches, they will suggest that morphine may decrease the absorption of oral antiplatelet agents. So because of this reason, fentanyl is the preferred opioid for analgesia in suspected acute coronary syndrome. So this is the primary management. So this is everything we know, but I just wanted to point you out what are the changes that they have made in their guideline. Bharti, we can go for the next slide. Yeah, then when we come into the hospital management, so usually any patient which is presenting to us, especially in the case of proven ACS, that is instituted in hospital include medical therapies, interventional cardiology procedures such as PCI, and surgical options like coronary artery biopsy or like any bypass, coronary artery bypass graft. So CABG is one of the choices. So usually what they say is any patient with ST elevation MI, what we will have to do as hospital management is pre-perfusion therapy. So we will have to re-establish blood flow into the occluded coronary artery. So to do that, usually we have two main methods, which is PCI and thrombolytic therapy. But usually the best one will be PCI. If we can't achieve PCI at the hospital, if it is unavailable, then we can go with the thrombolytic as the therapy. So in patient with ST elevation MI, angiography with coronary revascularization, PCI or CABG is the treatment of choice, or thrombolytics if PCI is unavailable within 90 minutes. So this 90 minutes is usually they say counted as from the first medical contact within 90 minutes, we will have to do it. And usually the best preferred thrombolytics will be altiplase and tenecteplase. And here in Australia, they have Aboriginals and Torres Strait Islanders, that they will be the, like, we will suggest that they are the main Australians in here. So they are the main ones. So for them, usually streptokinase is contraindicated because they will have some antibody that which will be reacting for that on streptokinase. Okay, Bharti, you can go to the next slide. So when we come into non-ST elevation MI, so when management of non-ST elevation MI, mainly the non-ST elevation MI, we will have to manage it as a plaque stabilization. So prevention of coronary occlusion with medical therapies mainly used than the surgical therapies. So what are the main medical therapies we use is anticoagulants and like mainly antiplatelet and anticoagulation therapies. And then after the end, like everything, when we consider, we can go with revascularization, mainly with stenting or bypass. But usually thrombolytic therapy is not used to treat in non-ST elevation acute coronary syndrome. So what are the other main important ones that they are mentioning are, so patient at very high or high acute risk of mortality and recurrent cardiovascular events should be immediately started on dual antiplatelet therapy and anticoagulated with a low molecular weight heparin or unfractionated heparin. And also usually unfractionated heparin is mainly used for patients with severe kidney impairments because they might have a high, and also patients who have high risk of active bleeding. Why it is used mainly? Because it will be easily reverse the anticoagulation effect of it. So if we use unfractionated heparin, we can rapidly reverse the anticoagulation effect than low molecular weight heparin. And they say do not use prasugrel or for patients who weight less than 60 kilograms and are aged 75 years or older, or who have had a previous stroke or TIA. And do not use tisagrelor for patients who have a second or third degree AV block. So this is the important points that they were highlighting in their guidelines. Bharti, we can change. So for the long-term management, what are the main drugs? So we will have to go with dual antiplatelet therapy. And they usually say dual antiplatelet therapy for 12 months. So when stopping the dual antiplatelet therapy, usually we will have to stop the clopidogrel, like the P2Y inhibitor, and then continue aspirin indefinitely. If the patient is contraindicated with aspirin, then we can consider indefinite therapy with clopid. And with the antiplatelet therapy, we will have to go with statin and some antihypertensive drugs. So for beta blocker ACE inhibitor is actually used in that case. And for the complications following MI, so they will have some complications which will follow myocardial infarctions. Mainly, it can be left ventricular failure, cardiogenic shocks, neural thrombus, any pericarditis, mainly Dressler syndrome, and any arrhythmias. Bharti, you can move. So I have just put a question like how the MC is giving questions like, so a 68-year-old man presenting to the emergency department with complaint of chest pain, which will radiate to the jaw for the past 2 hours. Patient is given aspirin. Like now we will come into the primary management. So they have given the primary management, aspirin they have given, GT, and they have given an oxygen also given. Maybe it is required, so they have given it already. So these measures are subsiding chest pain. So definitely then you don't have to go with morphine now. So an ECG is obtained and as is follows. So everyone I think can read it. So it has ST elevation there. So a troponin level is requested, but the result is still pending. Which one of the following is the most appropriate option of management? So now the patient is presenting to us within 2 hours of ST elevation MI. So as we discussed in the hospital management, what in the ST elevation MI, what we have to do is mainly we have to do the reperfusion therapy to re-establish the blood flow into the occluded coronary arteries. So to do reperfusion therapy, there are 2 main methods, PCI and thrombolysis. If they don't have any contraindication to PCI, or if they don't say that PCI is not available, then we will first have to go with that main choice. So PCI will be the answer here. And if they say that PCI cannot be done, or like it is not available at the moment, then we will have to go with thrombolysis. So I think this is a small idea that I have given to you about about ischemic heart disease. So it is just a part of cardiology. So we all know. So I wanted to show you like how it is when you actually study for the medicine part and when you actually study aiming AMC and how you will actually guide through AMC. So that is the difference for this exam. Like even though that we study and we have a good knowledge of theory, but sometimes it will be hard for us to answer a question and pass the exam, even though, because the only reason is their guidelines are a little, they will have a little difference that we will have to dig in and to be known before doing the exam. So that is all for my part, I think. Thank you very much for listening.
Thank you, Dr. Udara, for a wonderful presentation. So now your wait is over. The question round is absolutely open for you. So Dr. Akram is here. And if you have any query regarding the scientific part that has been taken care by Dr. Udara, we are ready to take your questions from here. So you can use the chat box, those who are joining from YouTube.
Yes, please. So basically, yes, Dr. Zamala is asking basically that if they completed their MBBS from like Russia, China, and all those countries, there is a MCI exam is mandatory. So it is not mandatory to be graduate. I mean, that's FMG pass and registered in India. Without registration in India, also you are eligible to sit in this exam. The only condition, your college must be in the World Directory of Medical Schools list. You are eligible to sit in the exam. And there's no any other question. Can you please directly you can unmute yourself and can ask here without joining from Gmeet.
Yeah, apart from that, I have shared one Google form in the chat box. So those who have joined are free to share their feedbacks and the queries through the form as well. So Arindam, can you help us with the queries?
Yes, Koi, is there any question? Can you please unmute yourself and ask the question, or maybe you can just type your question so we can read I'm seeing basically on the YouTube, so there is no question as such. So these are the numbers. You can call us or you can WhatsApp us on these numbers, or you can email us, or you can visit our website. And those are in Sydney, they can visit me in our office as well.
Sir, will you be available to share the this? Will you be able to share this Google form on the YouTube as well?
Yes.
So please follow it from the chat box here. Okay, so there's a query. When can we book for AMC, or what is the process? This is a question from Saroj.
When can we book for AMC? What is the process? So to book the exam, first you have to basically go for Epic verification, and you have to make your account on AMC website to upload your basically AMC portfolio. And once you are ready, then you can book the exam. So exam they conduct monthly. Whenever you are ready, you can give, except in December and January. They conduct monthly ones, so it's easier for you to go for this an exam. And we will help you to complete if you are joining academically for your documentation process as well. So please fill this form, so our team will get back to you.
Unmute yourself and come forward to share your query.
So Dr. Alicia KL, he's asking, hi doctor, can you please share the exam steps? So Lisa, Dr. Alicia, basically if you want to register yourself in Australia, so there is some steps you need to complete. The first step, basically your document verification. In means that you have to go for Epic verification plus AMC portfolio. We will help you to complete this process. No need to worry about this. And then next step is that this AMC exam part one, the MCQ based exam, as she already mentioned regarding this exam. So you have to book the exam, and you have to write in your home country, in India itself or whatever country. Okay, and then once you pass AMC part one, then you have to go for English a test like maybe PT, OET, or IELTS, and then you have to go for AMC part two. These are the 4 steps you need to complete in order to register yourself as a RMP in Australia. And the next question is from Pappu Kumar. Total time duration taken for the preparation. So Pappu will provide you basically around 15 weeks this preparation. So around 4 months, including the revision for last 2 weeks. So we will complete in this 4 months. So at least you need to study at least 4 to 5 hours per day for 4 months. So easily you can crack this exam. This is many students basically compare this exam with NEET PG. So Dr. Swapnil, are you here? So can you please give us some idea that how
Yeah.
is it a very easy exam or very tough exam as compared to NEET PG?
Uh, I think, Dr. Akram, we cannot compare both the exams because, as I pointed out during the presentation, in NEET, what you have to do is you have to struggle. You are struggling for a merit position, because if you will not get that merit position, you will not get the branch you would like to choose. So that is a completely different exam. You are working for a post graduation specialty.
Hmm.
Here, what AMC is not, when you give this exam is not for when you pass this exam, you cannot go directly into any specialty training or in a post graduation training. This exam is like an exit exam, you can say, when which we are listening. I don't know if that has been implemented in India or
Yes,
not, but
next
I have.
exam is going to implement in India. Next
Yeah,
exam.
it is the. I think we are hearing this since I graduated. My final year, the proposal was made, but I know. So you can compare that as in AMC, because, as I said, it is an exam which is testing your knowledge at intern level. So here you need to know more about that point of thing. So we cannot compare NEET PG and AMC on the basis of how tough it is, because this exam, the good point is out of 500, you have to score 250. You are not running after any merit position. So that need to be clear.
Okay. So one question is from what would be the total cost for this process? So I can say around 10 to 12,000 Australian dollars is going to be around 6 lakh around Indian rupees in total whole process. Step by step if we are going. So next question is from Dr. Lisha. Which is better, Dr. like OET or IELTS? So it's up to you, both is like language exam, but OET is easier as a medical doctor for you, as compared to IELTS, because they will ask you the questions regarding the healthcare related things only, If there's anything you need to write, so might be this is very related to you, whatever you are doing, you to do activities in hospitals. So OET is easier than IELTS or PTE also. So please go for PTE or OET as compared to IELTS. They are the easier exams to crack. And we give this form, so please fill this form. So our team will get back to you one-on-one. If you want to talk to us, if you have any other questions, and you can ask the questions. Basically, it's a feedback form basically. So you can fill this form, and we'll get back to you. Yes, Dr. Suraj, we will cover basically A to Z syllabus in this course, and including we'll also provide you the study materials, whatever you need to pass this exam. Books or guidelines, whatever we will provide you. I mean, whatever need basically for this exam. Or Dr. Sapna, if there is any few books, reference books for AMC, if you can just give us some answer.
Yeah, we have already addressed the same during the presentation. So in the presentation, we have addressed like what resources we follow, and when we do the course, we will give you all the material together. But if you guys actually need it, then I might share all the name of the books with our project manager Bharti, and she can circulate it with these students.
Yeah, sure, we'll do that.
Okay, guys. Is there any question from? Okay. Aridnam, is there any other question? I think
No.
Okay, so with this, we will have to end this session for today. So just keep tuned. You can just do regular checkup on our YouTube channels. We keep on coming up with such sessions. Apart from that, the regular information is circulated through this YouTube channel. So just subscribe to the channel and be a part of your learning journey with us. Thank you, everyone. Thank you, Dr. Akram. Thank you, Dr. Udara, Dr. Swapnil, and everyone who has joined the session today.
Thank you so much.
Thank you, sir. Thank you.
Bye.
Thank you.